Welcome back. Today, we're jumping right into Chapter 4 of our source material, focusing on blood-modifying agents. Specifically, we're looking at vitamins and hematopoietic growth factors, zooming in on vitamin B12 or cyanocobalamin. But look, we're not just going to sit here and read a list of pharmacological facts. No way! The goal of this explainer is to take that standard textbook checklist for vitamin B12 and turn it into a dynamic, real-world clinical playbook. Whether you're a practitioner or just really into how medical professionals handle patient care, we're going to break down exactly how this drug is managed safely, from the moment a patient walks in all the way to when they head home.
Okay, let's dive into this. Here's our roadmap for the explainer, following a 5-step patient care arc. First, the numbers, so our lab studies. Second, expected hurdles. Third, danger zones. Fourth, clinical practice. And finally, Step 5, empowering patients through education.
So, starting off with Section 1, the numbers, significant laboratory studies.
Before we even think about prepping an injection, our absolute first priority is getting that baseline data. We need a clear snapshot of the patient's internal chemistry right this second. Because think about it, without a baseline, if a patient's levels suddenly drop or spike later, we'd have no clue if it was the drug doing it or if they were already trending that way anyway. And in clinical pharmacology, flying blind? Yeah, that's never an option.
Now, let's break down the specific labs we've got to monitor. We're looking at 3 main tests: hematocrit, reticulocyte count, and potassium levels. Notice the timing here? We have to check these both before and after administration. Why? Well, the hematocrit and reticulocyte counts actually show us if the drug is working. Reticulocytes are just immature red blood cells, right? So when we give B12, we totally expect the bone marrow to wake up and start pumping these out. It's our proof that the treatment is effective. But take a look at that third row, potassium. The blood cells show efficacy, sure, but monitoring potassium is what literally keeps the patient alive. As those new blood cells are rapidly produced, they pull massive amounts of potassium out of the bloodstream and into the cells, which can cause blood potassium levels to absolutely plummet.
Moving right along to Sections 2 and 3, expected hurdles and danger zones.
And this brilliantly illustrates the physical effect the drug has on the body. As practitioners, we really have to distinguish between minor annoyances and actual medical emergencies. On the left, we've got our expected hurdles. These are localized, mild, and totally predictable. On the right, we have our red alert dangers. These are the severe, systemic toxicities that can threaten a patient's life. Categorizing them like this just instantly prioritizes our clinical response.
Let's look at the most common expected hurdle first: injection site pain. Since cyanocobalamin is usually given as an intramuscular or deep subcutaneous injection, things like localized pain, mild swelling, or redness at the site, entirely normal. It's a side effect patients should totally expect. And as a clinical professional, you can easily manage this just by rotating the injection sites and maybe applying a warm compress. It doesn't mean the drug is harming them at all. It's just a temporary, localized hurdle. No big deal.
But we definitely need to shift gears to the serious side of the spectrum. So the crucial point here is recognizing our red alert toxicities, hypokalemia and pulmonary edema. Like we just talked about with the labs, rapid red blood cell production consumes so much potassium, which leads to hypokalemia, dangerously low potassium in the blood. And that can cause lethal cardiac arrhythmias. Plus, as the blood volume expands with all those shiny new cells, the cardiovascular system can actually get overloaded. That leads to fluid backing up into the lungs, which is pulmonary edema. These are absolutely not minor annoyances. These are life-threatening toxicities that require immediate, aggressive intervention.
All right, Section 4, clinical practice, specifically nursing considerations.
Now that we know exactly what the drug does, both the good and the bad, we're moving from pharmacological theory into actual hands-on protocols. These are the strict, everyday clinical guardrails outlined in our texts that keep patients safe. They bridge that gap between just knowing about adverse effects and physically stopping them before they can do any harm.
Let's move to the next step and see how this builds into an exact chronological sequence a practitioner has to take to safely monitor a patient on B12. Step 1. Get those baseline vitals and labs. Like we said, you can't know where you're going if you don't know where you started. Step 2. Monitor potassium closely, especially in those first 48 hours when red blood cell production just goes into overdrive. Step 3. Continuously assess for signs of pulmonary edema. You've got to listen to the lungs for crackles, watch for shortness of breath, and keep an eye out for sudden weight gain. By structuring it this way, the whole task of patient monitoring turns into a highly focused, super manageable checklist.
And finally, Section 5, Empowering Patients Through Client Education.
This brings us to what is arguably the most important step in modern healthcare. We can do everything perfectly in the clinic, but if the patient goes home without understanding their treatment, we've failed them. Our ultimate goal is to transfer our clinical knowledge directly to the patient so they can advocate for themselves. These education protocols for safe self-administration are absolutely critical, mainly because a lot of patients will eventually be injecting B12 themselves at home. They need to know exactly how to inject, where to inject, and most importantly, when to call for help.
Now, what's really interesting about this slide is how we have to translate complex medical jargon into actionable, life-saving advice for the patient. Instead of throwing around phrases like monitor for hypokalemia, a nurse is going to say exactly this. You must report any muscle weakness or heart palpitations immediately, as these could be signs of dangerously low potassium. Just notice that phrasing. Plain language saves lives. It gives the patient specific physical feelings to watch out for, like weakness or a fluttering heart, so they know exactly when a normal side effect has crossed the line into a dangerous toxicity.
Which brings us to the end of our clinical playbook for vitamin B12. I want to leave you with this final thought. How does diligent monitoring of a single lab value like potassium transform a routine injection into a masterclass in patient safety? Well, it shows us that in pharmacology, there are literally no simple drugs. Every single intervention requires foresight, structured monitoring, and crystal clear communication. Understanding the why behind the labs and the side effects is the true heart of clinical pharmacology. Keep this structured approach in your back pocket the next time you encounter a drug profile. It honestly changes everything. Thanks so much for joining me on this Explainer of the Day, and I'll catch you next time as we keep breaking down the complexities of healthcare.